We would like to welcome all attendees to today's webinar, which is an introduction to Cognistat 5, a special version of the Cognistat assessment system. Cognistat 5 is designed for the risk assessment of delirium, mild cognitive impairment, and dementia. This presentation is aimed primarily at clinicians and does not require any previous experience with the original Cognistat paper test or its computerized version, the Cognistat assessment system. In the next 40 minutes, we will provide an overview of Cognistat 5, how it was designed, how it works, and how to use it. We will have time for discussion at the end, and you are invited to type your questions in the text box during the webinar for later presentation to our speaker. We are fortunate to have as our speaker Dr. Ralph Kernan, who is one of the 3 authors of the original Cognistat paper test, and who has played a key role in crafting Cognistat 5 and the Cognistat assessment system. Dr. Kernan has a PhD in clinical neuropsychology and maintains a practice in the San Francisco area. He specializes in the evaluation and treatment of patients with mild traumatic brain injury, vestibular trauma, and dementia. I will now turn the presentation over to Dr. Kernan.
Thank you, Richard. Welcome, everyone. I'm Dr. Kernan. I'm very pleased to introduce you to 2 of the newest Cognistat products, Cognistat 5 and the MCI index. Next slide. Cognistat was developed a long time ago, 1979, and it was developed for our own private use on a locked psychiatric unit. At that time, there were no adequate cognitive screening instruments, and this led to the design of this test. Since then, of course, it's been used throughout North America and translated into multiple languages, and has been one of the most highly regarded cognitive screening tests available. Next. We created Cognistat in its original paper form in 1979 and left the test unchanged for approximately 30 years after that, during which time about 250 research studies were conducted using and validating Cognistat. The last 7 years have been an intense effort on our part to develop new instruments based on the original Cognistat concept, including the online Cognistat assessment system, the introduction of score-based algorithms to provide clinical guidance, a kind of expert system, which culminated in the MCI index, which I'll be presenting shortly. We're currently working on a Cognistat sport concussion battery. Next. The world is faced with a growing need to evaluate and deal with dementia. The aging population, especially in the United States, is vastly expanding as the baby boomers reach retirement age, and there's more of a need today than ever for rapid dementia screening. Next. We also are operating now under the Affordable Care Act. This mandates cognitive screening as part of an annual wellness visit under Medicare, and it charges hospitals with adequate screening of patients both on admission and prior to discharge in order to ensure that readmissions do not take place for the same condition. Next slide. Unfortunately, most of cognitive screening has relied on global scores. You see here a listing of several of the most notable and established cognitive screening procedures, all of which use global scores. Next. There's a problem with global scores. Items from construction tasks, memory tasks, orientation tasks are all lumped together in a single score, even though there's a variety of patterns in dementia. And a single score can't possibly capture the various ways in which dementia presents itself. This leaves clinicians relying on a single composite cutting score, a number. Mini mental state uses 30 points, often around 26 points out of 30, which is insufficient to characterize what might be going on. No specific skill is evaluated in anything close to sufficient detail. And although you can compute age and education norms for various screening tests, it's very difficult to keep age and education factors in mind when you're using a single cutting score. This leads to an unacceptable number of both false positives and false negatives. False positives occur when anything like anxiety or depression interferes with the patient's concentration on the task and causes a loss of a few points on the scale. False negatives occur and have been well studied in educated individuals who are not challenged sufficiently by the procedure and either lose no points or only 1 or 2 points in taking a global score test. Next. We need a quick, reliable way of screening, and it has to be better than what we've had in the past. We need to be able to distinguish, in particular, transient deliriums from more permanent dementias. We need a test that will allow us to give functional feedback to families and patients about the nature of the disability. And we need a test that will give us enough of a measure of the skills involved so that we can follow the course of an illness as it recovers with treatment or deteriorates over time. Next. Delirium and confusion are potential complicating factors to the evaluation of dementia in a large number of cases. They're common in elderly patients, often medication-induced. They're usually treatable, and they're easily misdiagnosed as dementia. Next. Cognistat 5 has orientation and registration sections that serve as red flags to alert clinicians to the presence of anything that might be interfering with the test taking, either a delirium or confusion, which then, of course, can lead clinician to look for treatable conditions and help in diagnostics. Next, it's important to detect delirium. Many conditions are treatable, and we need to be able to be aware as much as possible when there's a treatable condition. Next. Cognistat 5 is based on 4 Cognistat subtests: the memory registration section, orientation, construction, and memory recall. Next. These 4 subtests are relatively straightforward. We insist on getting adequate registration of the 4 words for the memory subtest. if you do not ensure registration, you cannot measure memory. Too many screening tests for memory do sort of bypass this criterion. We insist that the 4 words for the memory test can be repeated twice successfully in a row without any prompting before we assume registration has taken place. Orientation is a standard test of orientation to person, place, and time based on a 12-point scale taken directly from Cognistat. The construction test is a 6-point scale. Mosaic designs using square tokens that are white, red, and half and half. This incorporates sensitivity to the time in which a patient takes in completing the design. The memory section is unusual because it has a graded way of evaluating memory, separating out free recall, cued recall, and recognition in a 12-point scale that has proven quite sensitive to the adequacy of memory. Next. Algorithms are different from test scores. Often clinicians are left with a single number or a percentile that has to be interpreted and is sometimes obscure in its meaning. We have included a set of expert system guidelines into Cognistat 5 for the orientation, construction, and memory sections. These automatically take into account age and education and give clinician guidance. Talk about the significance of a given score on a given subtest for a patient of this age and with that much education. We then combine the construction and memory subtest scores into a more complex algorithm that provides the MCI index scores and guidance related to the possibility of dementia. Next. This is the memory registration section taken directly from the test for a hypothetical patient. This patient, you can see, was given word group A, robin, carrot, piano, and green, and on the first trial was only able to give back 3 of the 4 words. The words were repeated. The patient was able to give all 4 words back. The patient was then asked to give them one more time and was able to do so. Reasonably good registration, but not perfect registration, and there's a caution that comes up when you're giving the test that notes the mild difficulty that took place and cautions the clinician using the test about interpretation of other scores. Next. This caution statement for the memory registration section is repeated in the scoring section of Cognistat 5 as you see in the blue. Next. This is the orientation section. You can see these are fairly standard questions. You might also notice the yellow question mark boxes to the left of some of these. This is available throughout the test so that a clinician can click on a question mark and gain information about the item or its meaning or its administration. Here, this hypothetical patient missed the date. Next. You can see that for this patient, missing the date is 11 out of 12 and is within the average range. So it's graphically presented as well as given a verbal guidance statement. Next. Memory and construction subtests are the major working aspects of Cognistat 5. They provide the data for the MCI index. It's well known in neuropsychology research that memory and constructions are the two leading edge factors for showing early signs of dementia. These two subtests from Cognistat have been shown to compare very well to standardized, more comprehensive neuropsychological tests: construction to block design, and memory to the California Verbal Learning Test. A study on traumatic brain injury showed very nice correlations between our subtests and these standardized tests. Next. Here's the construction subtest. You can see the 8 tiles on the left-hand box, and then the 3 designs that are part of the test. In giving this test, the clinician clicks the start box when the patient starts the design, the stop box when it's completed, and the time is automatically recorded with the score. And we see in this theoretical patient that the first 2 designs were done, but done with difficulty, taking almost the entire 60 seconds allowed, and the last design was failed. This gives 2 points on the construction test. Next slide. And here's the feedback for this. 2 out of 6 points is moderate impairment. Next slide. Here's the memory section from the Cognistat 5 for this same patient. The 4 words are first asked for in spontaneous recall, and only 1 of the 4 words is gotten correctly. The other 3 words are cued with category cues, and for this patient, 1 additional word is gotten correctly. Then, multiple choice lists are given in order to test for recognition, and a 3rd word is correctly gotten by this patient. 1 word's failed altogether. And the points are awarded accordingly. 3 points for spontaneous recall, 2 points for category cueing, 1 point for recognition, and no points for failure. 6 points total. Next slide. Here we see that 6 out of 12 is a significant degree of memory impairment, and it's in the moderate impairment range. Next slide. Now, the algorithm for the MCI index gives a sense of the degree of cognitive impairment that's found on Cognistat 5, and also gives a way of estimating the risk that this patient has, either the early or later stages of a dementia. It does this by incorporating scores with construction and memory and age and education, and provides guidance statements, as you'll see on the next slide. The index goes from 0, no indication, to 6 gradations of increasing likelihood of dementia. The first 3, 1, 2, and 3, are different degrees of likelihood of mild cognitive impairment, or MCI. The last 3 begin to talk about the presence of a dementia. Next slide. Here's the MCI index on our theoretical patient. And you will note that even though both the construction and the memory subtest algorithms were at a moderate degree of impairment, the combination suggests strongly the presence of a mixed dementia syndrome. And I'll point out that we do not only grade the degree of dementia, but talk about 3 types: mixed, spatial, for more construction than memory, and memory, for more memory than construction. Now, the yellow boxes that I was talking about earlier, you'll see on the next slide, when you click, gives information about what it is that the box is next to. And here it's the MCI index. Next slide. Very fortunate to have been able to associate with a major memory and dementia research center in a study comparing Cognistat and the MCI index with the results of more comprehensive neuropsychological testing. 13 patients were looked at. The neuropsychologist for the research group independently rated his comprehensive test results in categories of mild cognitive impairment or dementia or no impairment. And all 5 of the rated dementia cases had index scores varying from 4 to 6 in the dementia range according to the MCI index. 4 of the 5 MCI rated cases based on full testing had scores in the MCI index range 2 to 3, consistent with mild cognitive impairment. This produced a Spearman rank order correlation of 0.76, which was, I think, very substantial. And I want to show you the patient who we failed to agree with the comprehensive testing on the next slide. It's patient number 8. This is an 88-year-old man who was thought to have mild cognitive impairment on comprehensive testing, but received a 0 MCI index rating because the mild impairment, the degree of mild impairment on Cognistat 5 was judged by the algorithm to be within normal limits for this patient's age. Again, the algorithms help us have a judgment, and I think judgments can vary from one professional to another at this level of subtlety. Next slide, please. Present 2 real cases from our archives to show the use of the MCI index and Cognistat 5. This is a man who had hepatic encephalopathy because during his hospitalization he was inadvertently taken off his protein-restricted diet. So he was seen, next slide, initially for an evaluation and had a very significant degree of dementia on testing. With treatment, he very quickly showed improvement. Now, everything didn't go away, but we see an enormous improvement in the construction test and lesser improvements in the other areas with a less certain indication of a dementia. Again, the scores give us a way of rating change with treatment. Next slide, please. This is a man who was more educated, with a successful professional career, but substantial medical compromise and a probable severe concussion recently. Next slide, please. The neurologist knew this man was having significant cognitive problems, but wanted a better characterization of the degree of dementia that was present. I had the opportunity to do as much cognitive testing as I wanted, and I did quite a bit. But as part of answering his question, I administered Cognistat 5. And I found it very helpful in terms of giving feedback to this neurologist to be able to point to the MCI index score of 6 to underscore the severity of the dementia in this case. Next slide, please. In summary, we have a 5-minute screening tool, at least in normal cases, that allows you to look at delirium, mild cognitive impairment, and dementia fairly closely to a degree that allows it to match up well against more comprehensive neuropsychological testing. It has expert system algorithms that incorporate the normative database for age and education and provide clinical guidance to the users and a risk assessment for MCI and dementia. Lastly, the data that is accumulated can be stored in and retrieved from a secure electronic record system. This makes it very nice to accumulate cases over time and do comparison studies as needed. And that's the end of my presentation. Next, be happy to try to address any questions.
And so the first question we have is, are there any practice effects with repeated testing?
The most obvious area for practice effect on this test are the forward memory tests, and we have 3 separate versions of the 4 words. There is a lesser chance of a practice effect on the construction section, especially when you're evaluating people with disability. So I think that by having the alternative 4 words, we've taken care of the one place where confusion around a practice effect would be a true interference.
I have one question. I was wondering if we have any general idea how much time was spent by the neuropsychologist doing the more extensive study in the comparison. Are we talking about 30 minutes, 60 minutes? Any rough ideas?
We know what was in that test battery, and although we don't have a specific statement of how much time, I would estimate 2 to 3 hours of testing.
Thank you.
What was the comprehensive neuropsych battery used in our study?
What did it consist of? It consisted of portions of the Wechsler Intelligence Scale, the trail making test, the Boston Naming Test, the California Verbal Learning Test, too. And I don't have a list in front of me, so I don't know all else that was in it, but that was probably about half of what was in it.
Okay. Next question is, can Cognistat be administered on a tablet? And the answer is yes.
I'm glad you answered that.
Right. And another question, is there data on veteran population which is heavy in PTSD?
That's a good question. I guess implied in that question is what would be the impact of PTSD on these cognitive tests. We don't have specific data. Cognistat has been used by veterans hospitals around the country for some time now. So there is probably data on this topic that we just have not had access to, haven't seen, and don't know about. But we do not have specific data on patients with PTSD.
Okay. Next question. 2 to 3 hours of testing compared to 5, maybe, I assume it means 5 minutes, may be mute if sensitivity and specificity are vastly different in the 2 approaches.
No question about it. Should be no suggestion here that a 5-minute quickie is equivalent to a 3-hour assessment. There are huge differences. After a 3-hour assessment, one ought not to just be able to rate the likelihood of a dementia, but to specify in great detail all of the various functional areas that are involved in that dementia and give some sense of how much involved, how much disability there is. We don't pretend to match up with a comprehensive neuropsychological test battery, but we are pleased that we can compare in any way in terms of the simple rating of a dementia.
Next question. Is the test available in both paper copy and online?
Yes, it is.
Yes, in fact, it's available in 3 formats, 2 online and 1 paper version. And the 2 online versions are a standalone version and a web-based version. Next question. Is there further research other than the 13-subject comparison to neuropsych testing?
Yeah, and I'm afraid there's not. There's plenty of research on Cognistat, the original test, but there's not. This is pretty new stuff that we're presenting today, and there has not been research other than what I presented.
Okay. Do we have measures for effort built into this test?
No, we do not. In my mind, there's clinicians too often imagine it's much easier to get a sense of effort from some test that can be used in conjunction with another task, a cognitive test, in order to make statements about effort or a failure of effort. This is a quick screening test. Effort is assumed. That is, the clinician has to take responsibility with his or her patient to ensure that there's adequate effort being given during the taking of the test. But it would be unwieldy to try to evaluate effort in such a brief screening test.
Ralph, can I make just one comment?
Sure.
And that is that our measure of memory registration may be helpful in looking at certain kinds of diminished effort. If a person repeats the 4 words quickly after hearing them, then is told, I'll be asking you for those words in 5 or 10 minutes, I'd like to make sure you have all of them before we go ahead, and then quickly gives the 4 words again, that is some reassurance that a person is cooperating with you. The speed with which a person, yeah.
I think you have a good point. I mean, I didn't mean that you couldn't get some sense of a person's effort from observing them do the test. I think that's going to be right there. But there won't be some independent, quickie way of evaluating effort.
Right. We have a question if there is a French version of the test, and the answer is not yet. It will be available in French later on this year, but right now it's available in English and soon in Spanish and French. Is there any research comparing the new Cognistat to the previous?
Well, the new Cognistat, if you were watching closely, the 4 subtests we're using in Cognistat 5 are 4 subtests exactly from the old Cognistat. These subtests have been evaluated many times in many research studies. What we don't have enough research to validate is the actual index, apart from the preliminary study I went through with you.
We have a question, are there handouts? And yes, there's a manual that goes with Cognistat 5. And there is also a stimulus booklet that goes with it, and of course the tiles. So there is a Cognistat 5 starter kit which provides a lot of information on how to use the test, and also a guide to the MCI index. And yes, there's more information on the website about this, and there is a practice version of Cognistat 5 on the website, which is a computer-assisted Adobe Acrobat form, which people can try. Question here, why is orientation used to distinguish delirium from dementia? Wouldn't patients with dementia also have difficulty with orientation?
It varies widely, but your point's well taken. The more severe dementias become disoriented, not because they're lost in space, but because they don't remember. And when you have a patient with a more severe memory impairment, you'll definitely start to see orientation become eroded. Orientation is helpful, however, when you can overcome the registration problems with repeated trials and the patient's able to demonstrate somewhat better memory recall, but is having trouble staying focused and responding adequately on the orientation section. It's not that orientation gives you an automatic indication of how much delirium is present, but it gives you another factor that's not the same thing as memory to play off against the memory score in terms of clinical reasoning and diagnosis.
And our last question, and I'll leave it to you, Ralph, to interpret it because it's quite short. Construct validity ... inter-rater reliability ?
Well, there's no rating going on here. I think the constructs have validity because the two main features of Cognistat 5, constructions and memory, have been validated against two of the most widely accepted measures of their respective skills. In terms of rater reliability, there is no rater reliability. You simply give the test and the score generates the results, including the guidance statements and the MCI index.
I think we've answered all our questions, and that would conclude our webinar for today. I want to thank everyone for joining. We're very pleased to have seen so many people join us, and I would remind them that there will always be information available on www.cognistat.com, the website, about Cognistat 5, and there is a free trial version of Cognistat 5 active form on the website. Thank you all. Goodbye.
Thank you.